So good afternoon, everyone. Today I'm going to be presenting our paper titled Modeling Hepatitis C Virus Elimination in the United States. Are we on track to reach the incidence targets? So some of the background on our paper. The White House proposed a $12 billion plan to eliminate hepatitis C virus in the United States, and it's currently under congressional review. Secondly, it's estimated that there's 4 million adults with chronic HCV in the United States, and acute HCV diagnoses doubled from 2015 to 2022. There's also been some important changes in substance use, shaping the HCV epidemic in the United States. The opioid epidemic likely increased the PWD population size threefold from 2011 to 2018 to an estimated 3.7 million PWD in 2018. Lastly, the contamination of drug supply with fentanyl and increasing risk of overdose estimated to have led to a recent decline in the number of PWD in 2021, which was estimated using similar methods as previous analyses. Now, the aim of our model was to use epidemic modeling to assess whether the United States is on track to reach the HCV elimination targets, which is an 80% reduction in incidence and a 65% reduction in mortality. And if not, what level of intervention scale-up is required to reach those targets? Now let's talk about the model. So we have a dynamic, deterministic general population model of HCV transmission and disease progression, which is calibrated to the United States. Stratification was done based on age with 3 age categories. The HCV transmission risk, whether people were PWD or non-PWD, the HCV disease stage, and the diagnosis and treatment history status. Our model also incorporates population growth and demography. So here are the model's schematics we use for our model. I'm not going to go through in detail, but these are the disease stage compartments where we have individuals entering as susceptible, getting infected, and progressing through the different disease stages and different stages of diagnosis and treatment. Now let's talk about some of the key assumptions of our model. So we use a time-varying entry rate into the PWD population, which increases from 2012 to 2017, and this is based on an increase in the PWD population size. Secondly, PWD have a time-varying risk of drug-related mortality. The way we code that into the model is we have a linearly increasing risk of drug-related mortality from 2015 to 2025 through the progressive contamination of the drug supply with fentanyl. And by 2025, PWD have a 5-fold higher drug-related mortality risk during this period due to the introduction of fentanyl. And we vary this in the sensitivity analyses. Lastly, we have a time-varying transmission rate. So the first rate is from 1990 to 2002, and the second one is from 2003 onwards. And this is done to implicitly account for harm reduction scale-up in the early epidemic and changes in acute infection diagnoses. We model a fixed rate from 2003 onwards because harm reduction coverage remains low and there's no evidence of a recent change. Now let's talk about the model parameterization and calibration. The model was parameterized by published literature on natural history, and in order to incorporate parameter uncertainty, a sample of 500 parameter sets was drawn from the uncertainty distribution for each parameter. We seeded the model in 1990, and for each parameter set, we calibrate population growth, transmission, diagnosis, treatment, and PWD initiation rates using least square methods to 17 data points. The HCV treatment rates among PWD are unclear, so we calibrate the data for treatments among people aged 20 to 39 as a proxy for PWD. Now let's look at the calibration data. So first is the number of people with chronic HCV infection. We calibrate to about 4 million in 2020. Second is the number of PIID, which is 1.3 million in 2011 and then 3.7 million in 2018. Third, we look at the proportion of PIID with chronic HCV, which is 44% in 2018. We also look at the relative change in HCV incidence from 2011 to 2019 of about a 2.5-fold increase. And we also look at the number of HCV-related deaths in multiple years from 2011, 2015, and 2019. Next, we look at the proportion of people aware of their HCV infection of approximately 60%. And lastly, we look at various treatment calibration targets. So let's talk about some of the model scenarios. Using the calibrated model fits, we simulate HCV incidence and mortality until 2030 under the following scenarios. The status quo is continuation of historical diagnosis and treatment rates from 2024 onwards. The treatment scale-up among diagnosed only scenario, we scale up HCV treatment to 100% treated per year among all those that are diagnosed from 2024 onwards. The third one is a treatment scale-up with risk reduction. So in addition to scaling up treatment, we model a 20% reduction in transmission risk among PIID via harm reduction. And lastly, we have a diagnosis and treatment scale-up scenario where we calibrate to what level of diagnosis and treatment scale-up is required to reach the elimination targets. Now let's look at the model outputs. So first, we are going to see the PIID population size. And this figure shows that the trend in the PIID population size over time, helping us understand the broader context of HCV transmission and incidence. We see an increase in injecting initiation and the number of PIID up until 2018. And we see a decline subsequently with increasing fentanyl-associated drug-related mortality. And in this figure, you can see the two red calibration data points, which we calibrate the number of the PIID population size to. We also included a unpublished validation data point, which shows that there is a decline moving forward. Next, we look at the HCV incidence projections. The black solid line is the mean scenario, is the status quo scenario, the mean projections. The shaded area is the 95% confidence interval. And with increasing PIID population size, the model predicts an increase in HCV incidence from 2011 to 2018. We estimated about a 240,000 or so new infections in 2015 with wide confidence intervals. And we also see that the declining PIID population size and treatment reduces new infections to 125,000 by 2030, with a relative mean decrease of 47%. Now, without the PIID population size increase, HCV incidence would have declined, as we can see with the dotted red line. Next, we look at the impact of drug-related mortality. So we have three sensitivity scenarios. The model projections are sensitive to assumptions of impact of fentanyl on drug-related mortality. So if you see the purple line, more infections if there's no impact of fentanyl on overdose, and there's going to be fewer infections if fentanyl increases mortality by 7.5-fold. The HCV incidence projections. So as you can see over here, there's two slides, two figures, one for primary incidence, one for total incidence. So with 100% per year treatment rate amongst all those diagnosed, we see a decrease in primary infections, the figure shown on the left, but we see an increase in total infections because of reinfection, where the dotted yellow line shows this scenario. And unless combined with harm reduction expansion, achieving a 20% risk reduction, this will reduce the total incident. So what is needed for elimination? The incidence elimination target is possible by 2030 only if diagnosis is scaled up to a test every year and treatment of all those diagnosed. Now let's quickly look at the HCV mortality projections. With existing treatments, HCV-related mortality is projected to decline, but it's still going to fall short of the 65% reduction target. We see a 46% reduction by 2030. Now, if treatment is scaled up to all diagnosed, we could reduce HCV-related mortality by 79%. So some of our findings. So we're not on track to reach HCV incidence or mortality elimination goals in the US. We've estimated that there's about 240,000 or so new infections in 2024 with wide uncertainty. And it's a 3.5-fold higher estimate than the CDC estimates, which are based on multiplying acute HCV cases by a multiplier which is highly uncertain and was estimated a decade ago. This is similar to the estimates presented by Adelina Ardeni in today's earlier session. The opioid epidemic and fentanyl expansion have likely had profound changes on the landscape of HCV in the US, and elimination is achievable but requires committed funding and expansion of comprehensive testing, linkage, and treatment programs alongside harm reduction initiatives which could additionally prevent HIV and overdose. Lastly, I wanted to discuss some key uncertainties. There's uncertainty in the PWID population size and the impact of fentanyl on mortality, leading to uncertainty in the incidence estimation. There's also uncertainty due to changing drug markets and associated drug practices in the US. Example, any shifts from injecting to smoking among PWID, as is observed in urban centers in the Western United States, and how these will influence HCV risk and mortality in the future. Lastly, there's uncertainty in PWID treatment rates, and we need data on cascade of care among PWID. So what are the implications or next steps? Our model can be used to project impact of the White House initiative when information on distribution of treatments by setting or population will be available. We can monitor progress towards elimination and attach costs to generate a return on investment, including prevention benefits. And lastly, explicitly incorporating harm reduction to assess the impact of expanded access on elimination. And I'd like to acknowledge our funders and gratitude towards our collaborators. Thank you.
We're 5 minutes behind. Okay, thank you very much. I want to remind people in the room that you can submit questions via the app if you go to our session. We are running 5 minutes behind track, so we'll keep the questions to a minimum. If anybody has a question, feel free to raise your hand. There's a mic roaming in the room. And in the meantime, I have a question, which is about the utility of using 80% incidence reduction if it leads to a recommendation of 100% treatment, which we know is, ideally it would be helpful to make feasible recommendations that could be implemented. So, did you consider adjusting your model to look at a different endpoint when you realized that you had to model scenarios of 100% treatment uptake so that you could look at an adjusted goal, because globally, not all countries will be able to achieve that 80% target?
Not as of yet, but I'd like to remind there's a lot of uncertainties, especially with the PWID population size. And a lot of the incidence was, at least in our model, was being driven by that increase in the PWID population size. Secondly, there's uncertainty regarding fentanyl, whether the amount of mortality related to fentanyl is actually driving down the PWID's population size. And so those two factors are really important that we need to consider for the model.
Yeah,
Matt.
thank you.
Yeah, hi. That's a great model. I wonder, as you're saying that the issue around PWID, or people who inject drugs, population size, are there any regions? So can you use a model to model states where you might have a bit more confidence in some of the estimates and then see whether you've got similar findings?
That's a good question. We do have a different model where we look at a local data. I suppose it would depend on the data itself. So really quickly, the PWID population size estimates that we use are from a paper. And the way they estimated these sizes is they essentially looked at the number of non-fatal overdoses, and then they looked at the prevalence of non-fatal overdoses amongst current PWID. And then they divided that by the prevalence of the number of non-fatal overdoses among current PWID. And that's how they got the PWID population size. So yeah, there's a lot of uncertainty in the PWID population size, but these are the best estimates that we have that we're using. But the good point is the population size estimates that we use in our model are consistent, as in they're using the same methodology. So the trend would still be applicable, even though the numbers might be off.
Okay.
And actually, in the slide, you see there's a very wide uncertainty with that population size estimate itself.
Okay.
Thank you very much. So we're going to have to keep moving on to our next speaker now.
Okay.